of pediatric disability, women's health, sport injury, kids continence, and ECEI coordination with the NDIS. She takes a collaborative approach to therapy by involving the family to get the best outcomes for their child, and integrates her professional understanding of the NDIS from her work as an ECEI coordinator. Also, as a NAPA parent, she has a child that comes to NAPA as well. Kelly understands the importance of working with a great team, and she has a passion for working with families to make a meaningful difference. So Kelly offers continence physiotherapy, which is a specialist area to assist families in achieving their goals. She provides comprehensive continence assessments, including reports and recommendations and quotes for consumables and equipment to assist families in securing the NDIS funding required to achieve their continence goals. So Kelly treats in the community and also at NAPA. She treats via telehealth as well. You can see her at NAPA every Wednesday. And she also treats out of a clinic out at Terry Hills. Is that right, Kelly? Terry Hills as well, and also does some community work as well. So she will talk you through all her contact details are on the screen there. But if you do want to reach out to Kelly at any time, you can reach out to her directly and make an appointment directly with Kelly. If you are interested in seeing Kelly while she's at NAPA on Wednesdays, you still do make your appointment with Kelly directly with her as well. So a couple of quick housekeeping things before we get into Kelly's presentation. As I said, we will be recording. If you do have questions, I'm sure there's going to be a million questions that pop up tonight. Rather than forgetting, we're going to have time for questions at the end of the session. Rather than thinking of a question and forgetting it, I'm going to encourage you all to pop it into the chat function. You should see a little chat bubble at the top of your screen. Pop your question there at any time during the night, and we will get to as many of those questions at the end of the presentation as we can. Please be mindful that we will try and tackle only sort of generalized questions and questions where the answer may be applicable to lots of people tuning in tonight, as we may not be able to get into your child's specific needs in a public forum like this. But if there is something very, very specific or a question specifically about your child that you want to ask, we do encourage you to reach out to Kelly, and she can have a one-on-one consult with you at any time. All right. So without further ado, I will just encourage you all to remember to keep your cameras and your microphones off, and we will pass over to Kelly, and I will come back onto camera once we're doing the Q&A at the end of the session. Thanks, Kelly.
Thank you, Paul. Thank you, everyone, for being here as a starting point, taking some time out of your evening to hopefully learn a little bit more in terms of how continence physio might be able to help you and your child. Thank you for the intro, Paul. I do feel really privileged that I can work alongside NAPA on a Wednesday, work with some of the amazing therapists there, and then work with some of the fantastic families that are at NAPA. It's a fantastic place to be, and it's a really good place to work with. Some of you might have seen me there as a therapist, and like Paul said, some of you will have seen me there as a parent as well. So let's move on. Oh, why am I stuck? Hang on. Do it this way. There we go. So as a way of introduction, so as Paul mentioned, I've been a physio for quite a while. I did qualify in the UK, but I have been in Australia for about 16 or 17 years now. So I'm a member of the Australian Physiotherapy Association. My postgrad training has been in women's health and kids continence, and I'm a member of the Continence Foundation of Australia and the International Children's Continence Society. On top of that, as Paul mentioned, I am a NAPA parent. I do have a fairly complex child of my own. So I know that everybody's journey is very different, but I do feel as though it gives me a little bit of an insight into some of the challenges that we go through as parents with slightly more complex children. Okay. So moving on from the introductions, this isn't going to be a talk about how to toilet train your child. It's more, I guess, when families initially get in contact with me, a lot of them say, oh, I didn't know continence physiotherapy existed, or I didn't know this was available for my child. So there's not a lot of us out there that work specifically with children. So it was to, I guess, hopefully create a little bit more of an understanding about how continence physio might be able to be of benefit to your child and what that might look like, how it might work. We're going to go through some of the basic anatomy when it comes to toileting and some developmental expectations. And then we'll have a chat about when is it worthwhile seeking help and what that might look like. We're going to have a bit more of a conversation around constipation. So constipation is something that I see a lot of. It's very prevalent in kids with complex needs, and it's super important to address constipation before you can expect successful toilet training and before you can address any urinary incontinence, just because bowel function can impact bladder function. We'll then have a little look at what I would class as pre-toilet training versus toilet training and what you're kind of focusing on in those different times. Okay. So what is kids continence physiotherapy? Like Paul mentioned, it's a specialist area of physiotherapy. It's a little bit niche. It involves specific training around the pelvic floor, kids specifically from a continence point of view, as opposed to adults. It is a little bit different the way that we work. And what sort of things do we work with? So we help families that might have kids experiencing delayed toilet training, urinary incontinence, fecal incontinence, that could be daytime or nighttime, and constipation. So quite often families come to me and it's we'd really like to start toilet training, but we don't really know where to start, or we're kind of partway down that journey and, you know, there's stumbling blocks along the way, and it's like, where do we go and what do we need to do? And what are the things that might be impacting that? So yeah, quite a range of things. And like I said, quite niche, but I feel as though I've kind of, I guess, worked in different areas of physiotherapy and found that, you know, that for me, this is a really good place. It can really make a difference. I feel as though when you've got a child with complex needs, toilet training can often be put on the back burner because you're focusing on speech, you're focusing on gross motor development, fine motor, school readiness, all that kind of stuff. But I think when families do kind of get to that point where it's time to start addressing some of these issues, it can be really life-changing. It's really beneficial, and I do really enjoy working in this area. So when to see a continence physio. So Paul touched on it earlier in terms of some of the things that I can offer as part of what I do. As a physio, we always do an assessment. So there's definitely that assessment part of it. And I offer that via telehealth so that I can work with families throughout Australia. And from that assessment, we can then look at doing a full NDIS continence report. And with that, we can justify why we want extra funding to be able to work on these goals. So why do you need extra funding for physio on top of potentially the physio funding that you've already got for your gross motor skill development? We can look at requesting in that funding for consumables. So, you know, your nappies, all that kind of stuff, but also for the low cost assistive technology that we might need to be able to optimize the toilet setup so that we're going to get as much success as possible. And all that can go in the report. It's a really robust report to try and justify that being reasonable and necessary to the NDIS. I also see families that are looking for some skill development and toilet training, you know, where to start, what to do, what are the things to focus on? Are there any physical factors that are, you know, slowing things down that we can work on to improve things? Constipation, pain, withholding, straining, fear or avoiding doing a bowel motion. Absolutely. That's a type of child that I would definitely want to see to work out, you know, why is this happening and how can we improve that for them? Also see children that might have slow urinary flow, some hesitancy or a bit of a staccato flow, so kind of a stop-start flow. That indicates that the pelvic floor isn't working quite as we would hope for in terms of a function. And then children that might have less than 3 or more than 8 wheeze per day. Again, that's something that we can look at investigating a little bit further and trying to work out why and then how can we help that. I also work with families who have children that are still experiencing daytime leaks, and that could be for wheeze or poos after being toilet trained. And then children that haven't yet achieved nighttime dryness once they turn 5 or 6 months after toilet training. So we can certainly look up how we might be able to help in terms of bedwetting as well. If you've got a child that will only do a poo in standing or in lying, again, that's something that we can help with. That indicates that they haven't quite worked out how to coordinate their body, how to use their core, how to use their breathing, how to use their diaphragm to be able to do their poo in that kind of seated squatting position on the toilet. And then sometimes what you find in that is, you can tell they're doing a poo because they're standing up, they've got their little poo face, you know what they're doing, you try to sit them on the toilet and all of a sudden it's like, oh, they're withholding, they're not doing that, they don't want to do the poo. Chances are it's actually a coordination, a physical factor that's causing it, as opposed to them not wanting to do it. But it can then lead to some sort of reluctance to sit on the toilet because it's hard and they can't do that. There's just a little bit of an asterisk down there. If your child needs has a stoma or a catheter, that is out of my scope as a physio, and I would look at referring you to a continence nurse for care around that. So I hope that gives you a little bit of an understanding as to the sorts of things that we might look at. So how do I work? As I said, always do typically my initial assessment via telehealth. It's just a huge information gathering session to really help me to understand all the complexities, all the needs, the background, everything that's gone on with your child so far. If you started toilet training, what's worked, what hasn't worked. There's always an element of problem solving in there. So, families always come with a problem of some sort, and it's then about clinically reasoning, why is that happening and what do we do about it? If it's possible geographically, I always really like to do a face-to-face physical assessment, which helps me to understand their body and how that might be impacting bowel function, how that might be impacting pelvic floor function. Now, I'm based in Sydney, so obviously it's not always geographically possible, but what I do then is I liaise with your existing therapy team, probably your physio, but maybe your OT, to look at, are there some things that they can specifically assess for me when they see you on that weekly basis? And then if we can communicate around that, what are the things that we would prioritise that are also going to help their toileting and their continence, but also can be part of their sessions in terms of the other goals that they're working on. I like to provide tools for families to be able to overcome challenges. So that might be, links to resources, that might be language to use around certain, certain outcomes, certain behaviors, certain instances. And then, physical hands-on approaches, whether that's exercises or teaching how to do a tummy massage. So yeah, providing parents with just different tools that they can have in their toolbox for different scenarios. There's a lot of family education and support involved in what I do. So I often have ongoing telehealth sessions with families to check in and kind of be like, okay, well, where are we now? What's going on? What's worked? What hasn't worked? What do we do next? How do we support school and daycare into, implementing that routine and trying to create more independence? If possible, ongoing face-to-face therapy sessions. Obviously, being very careful not to overlap and duplicate any services from an NDIS point of view with your existing therapy team. But it might be that, you haven't got a physiotherapist, or it might be you've already got lots and lots of goals that you're working on, and therefore can we allocate some time to specifically look at how their body is working and what we need to work on to improve things from a continence point of view. I kind of touched on it earlier, but team engagement is really important as far as I'm concerned. So, if we've got a team that's got speech, OT, physio, can we get everybody as part of their session, working on even the smaller aspects that might help that bigger goal of working towards being toilet trained and independent? And then medical referrals. So, if you're presenting with a child that's got a particular concern, let's take constipation, for example, it might be that we kind of like, well, can you get in touch with your GP? Is it possible that they can refer you for an abdominal X-ray or an ultrasound to look at transverse rectal diameter to give us a baseline idea of what's going on right now, so that we can then compare that in the future when we've looked at, some treatment sessions. All right, so I thought we'd just go over a little bit of kind of basic anatomy and function. Now, the next few diagrams that you're going to see, they're not medically accurate. They're just for sort of diagram purposes. But if we chat about bowel anatomy and function to start with, what does a bowel do? So it's basically responsible for eating and excreting. So it processes the food. We eat, the food goes down the esophagus into the stomach, where it's mixed with the stomach acid, and from there that kind of I guess liquid food passes down into the small intestines in here, and that's where it gets processed and the nutrients that the body needs are taken out. And basically the waste then passes through here, the little ileocecal valve, into the large intestine, and from here it goes up, along, down that left hand side of the body and into the rectum. And it moves there through what we call gut peristalsis. So it's smooth muscle, and it's almost like little squeezes along to kind of move the waste along as it's forming the stool. And as it's moving along, the large intestine's job is to take water out of that. So we start to get stool formation. It then comes down into the rectum, and the rectum is a signaling device, and it basically sends a message to the brain to say, hey, we need to poo. Essentially find a toilet, which is obviously best case scenario, and that's when we can then eliminate the waste. In terms of developmental expectations, if we're looking at kind of toilet training somewhere between 2 and 3 in a typical child, we know that's often delayed when we've got children with more complex presentations, but we're looking at around probably a daily bowel motion once we hit 3 years old. So if your child is doing several bowel motions per day and they're smaller, and we're kind of thinking, well, why are they not able to completely empty? Again, that's something that we can look at trying to improve. If they're going for days without doing a bowel motion, again, what's going on there? Have they got slow gut motility? And how do we improve that? How do we treat that? In terms of bladder anatomy and function, so what does the bladder do? It basically stores and expels urine. So we've got the kidneys. Typically we're born with 2 kidneys, one on either side, and they filter, and basically the waste goes down the ureters into the bladder. So the bladder's the little green, it's like a balloon at the bottom, and it's surrounded by a smooth muscle called a detrusor, and that allows it to basically get bigger and bigger as more urine goes in there, and it periodically sends messages to the brain and signals as and when we need to go, and it reaches a point where it's time to go. That message from the brain then comes and we go to the toilet. Obviously this is ideal scenario. We can relax our pelvic floor, the detrusor can contract, and we empty the bladder. In terms of developmental expectations, around 3 years old, again, this is based on kind of when you might start toilet training, we'd probably expect children to be able to hold for about 2 hours. So if we are creating a routine for a child that's not necessarily feeling the urge, if they're only holding for an hour, it's going to really interrupt the day if we're sort of stopping them every hour to sit them on the toilet. So, when they get to the stage where they can hold for, approaching 2 hours, that's probably a good time to start creating a routine. And in terms of a typically developing child, we're looking at probably that 3.5 years old-ish to be fully toilet trained. Girls usually a little bit earlier than boys, and nighttime is typically 6 months after daytime toilet training has been achieved. So, a lot of the families that I work with they've got, kids that attend NAPA, kids that are a little bit more complex in terms of their needs, they tend to be older as opposed to that kind of 2 or 3 year old mark. But for me, at any point, I'm more than happy to start working with you guys to work out how do we create more independence? How do we improve what's going on from a continence and toileting point of view? Just wanted to kind of go a little bit through the pelvic floor in terms of anatomy and function. Again, very just kind of diagrammatic picture, but what does the pelvic floor do? It supports the pelvic organs. So in a female, we've got the bladder, the uterus, and the rectum. Obviously in a male, we haven't got the uterus, but it's supporting the pelvic organs. So they're creating a downward pressure, and the pelvic floor sits either side, so in the pelvis. So if you're looking down directly on your pelvis, it sits in the bottom in there, and we've got a left side and a right side. It attaches to the front, to the pubic bone. It creates a sling, and it attaches to the coccyx, to the sacrum at the back. It helps us with continence control. So ideal scenarios, we can contract our pelvic floor and maintain continence, and then we can relax the pelvic floor and do wheeze and poos on the toilet. It also plays a really important part in core stabilization. So it works with the diaphragm. So you've got your pelvic floor, you've got the diaphragm, you've then got the muscles on the front and then the muscles on the back. And that creates our core, and it's really important for core stabilization. One of the things I wanted to highlight about the pelvic floor is that it compensates. So this is when we tend to I guess come across more, what's the word I'm looking for? I guess issues. So why is it compensated? So the pelvic floor compensates sometimes if we've got a weak core. So if we've got limited core stability, the pelvic floor can compensate. If we've got weakness or asymmetry around the hips, or we've got tight tissues around the calves. These are all things that might lead to compensations in the pelvic floor. And what we typically see there is we get more tension in the pelvic floor. Now, with that, that's almost like if you imagine you're at the supermarket and you need a wee, you squeeze your pelvic floor, and it sends a message to the brain of, it's not a good time to go to the toilet right now. But that additional tension in the pelvic floor over prolonged periods of time because of those compensation can, in some of our kids, send that message to the brain pretty much continually of, it's not a good time to go to the toilet right now. And they can actually switch off to that. So it's really important that we address the reasons for that compensation so the pelvic floor can work really well. It can support the pelvic organs, it can help with continence control, it can play its role in core stabilization. So yeah, in terms of developmental expectations, around 2 years old, again, in typically developing kids, is when we would see some sort of control over pelvic floor coordination. And that's why typically after 2 is when you would start to toilet train, because kids are starting to get a little bit of an awareness around that. Okay. Constipation and fecal impaction. So this is a huge part of what I do and how I support families on a daily basis. And it's really important because while we've got constipation, we can't expect kids to sit on the toilet. We can't expect kids to be able to do poos on the toilet. Bowel function can impact bladder function. That could be daytime or nighttime. And if we look at the research suggests that over 50% of children with complex disabilities experience constipation. And that could be intellectual disability, physical disability, or children that are neurodivergent. And this is kind of all of the kids that I might work with. So it's very common, is constipation. And if we look at what we might typically expect or what we might talk about in terms of constipation, it would be less than 3 bowel motions per week. It would be, if we look on the Bristol stool chart on the right hand side, type 1, type 2, or type 3 bowel motions. So your type 1 are like your little hard nuggets, like your little rabbit droppings. Type 2 are essentially your little type 1s squished together, and they can be quite hard, wide bowel motions. Type 3 is a little bit softer, but still probably a little harder than I would ideally like. And your type 4, the soft, smooth sausage, is essentially what we're aiming for. So any child that's got hard bowel motions, painful, wide bowel motions, if you're ever kind of going, oh my goodness, how did you possibly do that? That is something that we want to address, definitely. And physiotherapy is one of the things that can help to address with that. So I guess essentially when I'm talking about constipation, I'm talking about not effectively emptying the bowel. So that could be a child that has 3, 4 smaller bowel motions in a day, and families will be like, oh no, they do a poo on a regular basis, but we're not emptying the bowel properly. And for me, that's something that we can definitely help with, because if we're not emptying properly, there's risk that we are getting build up. And with that build up, we can then end up with fecal impaction. And with that, we can end up with leaking and smearing and overflow. Now, overflow is basically, if you imagine the inside of the intestine is not smooth, so it's little bits of stool can kind of get caught in there, and essentially you get, your type 1 or your type 2 stools forming. If it stays there longer, more water is drawn out and it gets harder. But what we can get is, like, let's say your type 2 bowel motion stuck in the rectum, and it's almost like a jar of marbles that you can still pour water through. So the newer kind of more liquid stool can seep through the little gaps in that bigger, harder stool that's sitting in the rectum. And kids are not even aware of the fact that it's happened, but they will then have that overflow. And that could be small little smears, or it could be bigger volumes. So, I guess what we're looking for is a ideal scenario would be a bowel motion roughly the same time each day. Ideally that type 4, not straining to evacuate the bowels, and a decent volume. So probably the size of your little one's fist or bigger. So if we're talking like a teaspoon or a tablespoon, we're not emptying properly, and we want to work out how we can help that child get better evacuation of their bowels. Okay. So causes and treatment approaches of constipation. So for me, it's really, really important that we treat the cause of the constipation before we try to toilet train, or before we try to manage any urinary incontinence. And there are lots and lots of different causes of constipation. And for some children, it might be more than one cause in isolation. So it's important to consider what those different causes are. And it could be food intolerances. So it could be more obvious things in terms of gluten or lactose, cow's milk protein. But I think there are also things in there, and I believe, I might be wrong, I believe it's IgGs that you can get tested for in terms of food intolerances that might be causing issues in terms of bowel motions and constipation. Children that have potentially eczema, rashes on the tummy, rashes on the back of their arms, that can all indicate that there's potential food intolerances. I think that's worth exploring further and chatting to your GP about that. Inadequate fluids is often a big factor in constipation. So if there isn't enough water going into the system, we can end up with harder, drier stools. Now, often this is tricky for families when kids go off to daycare or when they go off to school, and it's not mum or dad kind of prompting, being like, hey, have a drink, because kids get busy when they're at daycare or when they're at school. They get distracted, and there's less adult prompting. So we do often find that that's when kids might get a little bit dehydrated and become more prone to constipation. There are medical conditions that might cause constipation, like your Hirschsprung's disease. There are also kids I see that have slower gut motility, and therefore more water is drawn out of that stool, which can lead to constipation. And there are children I work with that have what we call pelvic floor dyssynergia. So this is where the pelvic floor isn't necessarily doing exactly what we want it to do. There's more tension in there, and the child can't actually relax it. So it makes it more difficult to get the stool out. That can sometimes present as withholding, or it might be just they are actually consciously withholding. So often children don't want to do a poo while they're at daycare, or they don't want to do a poo while they're at school. And I think, if they're withholding at school, but then they're fully emptying in the afternoon or evening when they get home, that's fine if we're still getting good emptying on a daily basis. If we look at treatment approaches, so medications are often first line treatment. Families kind of getting to a stage where, you know, the frequency of has decreased of their child's stools, or it's really hard for the child to evacuate their bowels. You know, they're screaming in pain, bless them. And you know, the first port of call is typically the GP, which I think is fantastic. Always get things checked out medically, and often one of the approaches is to start a stool softener such as Osmolax or Movicol, potentially a stimulant laxative like your little Dulcolax drops or your Laxettes. And they've definitely got a place in management of constipation with some children, but I think it's not, I think for me, it's just appreciating that that's not the only way to look at treating constipation. There are other things that we need to put in place with that. So hopefully, eventually, my aim is to try and reduce those medications and work out how we can just physically get their body working better. There's lifestyle factors, so you know, things like routine, fluid intake, fiber intake, what's the toilet setup like? That's something that we'll always go through. Sensory regulation is huge when it comes to constipation and toileting in general. So kids that live in that kind of that sympathetic drive, so they're in that fight or flight mode, it's really difficult to have good gut function in that scenario. So we do tend to find that kids that are more anxious, more kind of fight or flight, they struggle with their breathing regulation, are often more constipated. Ideally, what we want is the parasympathetic nervous system active, which is that rest and digest, which we get better gut function and less likely to get constipation. And then physiotherapy. So obviously this is absolutely where I come in. Discussions around all the other things are part of the assessment, but physiotherapy to work out how can we improve the gut motility? So if your child has slower gut motility, how can we improve that for them? If they do have pelvic floor dysfunction, how do we improve that? What are the causative factors and how do we improve that? So that's kind of I guess my approach in terms of looking at things quite holistically to improve constipation. So what does physiotherapy assessment and treatment involve? So I take a whole body approach to my physiotherapy assessments. So I don't do pelvic floor assessments on children. From working with adults, I know from an adult point of view, it's difficult for adults to understand, comprehend, kind of plan and organize their body to make the pelvic floor do what they want it to do. And in children, that's even more difficult. So for me, it's about understanding everything else that's going on in their body and how it's working that can impact the pelvic floor function, and how do we go about addressing that. Always tend to look at assessing the toilet sitting, the position, the mechanics, looking at kind of the breathing, the blowing, what's going on with that intra-abdominal pressure. Core strength is a key part of what's going on and how we successfully treat and manage. Tethered oral tissue can impact pelvic floor function. So from a fascial point of view, now if your child does have tethered oral tissue, so tongue tie, lip tie, cheek tie, that's something that I would look at referring on to a speech pathologist that has experience working with tethered oral tissue, or maybe a specialist pediatric dentist, just to make sure that we're kind of not missing anything that might also be contributing to toileting success. I'm looking for symmetry, strength, mobility. I'm looking for restricted tissue, all of these things that can impact how the pelvic floor compensates, what's going on from an abdominal and gut point of view, and how the diaphragm can work. And all of this is kind of, you know, part of gross motor function, like how do they move? How do they get up off the floor? How do they sit down? Do they roll? What does that look like? Along with some specific kind of range of motion tests. And, you know, the reality is that kids don't want to just necessarily conform to an assessment for an hour. So, you know, we're really flexible within that session about how we do it, and we chop and change, and we do what we need to do to get through the assessment. But for me, it's very much about building that connection with the child so that they're happy to have some of these assessments done in terms of looking at sort of range of motion and things like that. For me, breathing coordination and pressure management is key as well. So, if kids are breathing apically, so they're breathing just kind of up here, we're probably not getting a lot of diaphragmatic movement. And we need good diaphragmatic movement to get good pelvic floor movement and to create good intra-abdominal pressure, which helps to actually get the wheeze and poos out. Oh, I would also look at primitive reflexes. So there are sometimes when primitive reflexes are retained, that if we can help to integrate those, that can also help with what's going on from a toileting and continence point of view, in the fact that they impact core, they impact coordination, and all of these things can impact how the pelvic floor works. Okay. So if we have a little look at toilet training and what goals might look like, and the reality is that that's very different for every family that I work with. For some families, the overall goal might be to be toilet trained and to be continent. And for other families, that's not a realistic goal for their child. So, we're looking at how do we create a really good routine to optimize social continence and to increase independence. And for me, it's working with you as a family to make sure that everything is really, really individualized, and that we're breaking down those goals into smaller, achievable steps rather than feeling like we're overwhelming you or overwhelming your child. So if we look at what we need to be toilet trained and continent, the child needs to have that internal motivation to want to do wheeze and poos on the toilet, to want to kind of look after their body. They need to be able to sense the urge to wee and poo and to recognize that sense and know what to do about it. They also need the physical ability to get to the toilet, the fine motor skills to pull pants up and down, the ability to get on and off the toilet. They need to be able to relax their pelvic floor and use their core function. And they need the cognitive ability to understand all of those different steps in the routine and not get distracted along the way. So I guess what I'm saying is it's really quite complex and there are lots of different parts involved. And this is why it's always useful to actually get the full team involved, and work on different aspects that might contribute to that overall goal of toileting independence. So toileting goals look different for everybody, and we just make it individual and work towards what you want to work towards as a family. If we talk about pre-toilet training versus toilet training, so pre-toilet training for me is they're still in pull-ups, and toilet training is where you're actually going to transition into undies. So pre-toilet training for me is developing all of those physical building blocks that we need to be able to toilet. And in a typically developing child, this would come through play, but in a lot of our kids, it's through therapy activities. So we're developing body awareness, global coordination. We're looking at breathing coordination. We're looking at core strength. We're looking at how to engage the core. We're looking at it, static and dynamic. We're looking at hip mobility and strength, and we're looking at sensory awareness. So these are all factors that, they're going to really impact how successful toilet training is. In that pre-toilet training period, we also really want to look at constipation management. So I'm not going to talk about that any further, but it is absolutely key that we have really good constipation management prior to trying to actually toilet train. We want to make sure in that time that we've got the toilet set up really, really well. So what I mean by that is that could be low-cost assistive technology for a child that's got pretty good balance. It could be that we need specialist disability equipment for a child that needs more trunk support, can't sit independently. But what we want to do with that is we want to optimize position so that we're going to get more success on the toilet. And that's going to involve, I'm going to say for most kids, an insert in the toilet. So I really like the family toilet seat, which is like a little a little smaller insert that sits inside the toilet. You can get them from Bunnings, you can get them from disability shops, but they create really nice stability and take away that fear of falling down the toilet, which creates a little bit of tension through all of the muscles. It creates tension through the pelvic floor and just reduces success. So definitely most kids will need some sort of a smaller insert, and that's a really nice option. And then a footrest to make sure that we've got knees higher than hips. Now, ideal scenario, if we've got enough range through the ankles, we want the feet flat so that the heels are resting. We've got a nice stable base, and we want their knees higher than their hips. And the reason we want that is there's a little muscle in the pelvic floor called the puborectalis. Now, it starts at the front of the pubic bone and it loops itself around the rectum. And its job in life is basically to create a kink in the rectum. So if you imagine you've got your garden hose and you've got water flowing and you create a kink, it stops that flow. So essentially, what that puborectalis is, it creates a little bit of a kink in the rectum and helps to keep us continent. When we sit with our knees higher than our hips, we allow that muscle to lengthen a little bit, which allows the rectum to become straight, which just means we can pass stool a lot easier. So this is often something that I'll chat with families. We'll look at measurements, we'll look at what their existing toilet setup looks like, to make sure that we're really trying to optimize that for their child. In addition to that, in the pre-toilet training, we're also looking at setting the scene, developing their awareness, developing their understanding, lots of modeling of language. Now, that could be verbal language, it could be keyword sign, it could be on an AAC device. And it might be that we go, do you know what, hey, next time you see your speechy, can we make sure that we've got the right buttons on their AAC device so that we can start modeling that for them? Can we create visuals to start modeling around the house? And then when you take them to the toilet, you're tapping on the visual to indicate this is how you can tell me you need to go. So there's lots and lots of work to be doing in that pre-toilet training. And within that, we're looking at setting up a good routine. And then toilet training is when you start to transition into undies, when they're actually recognizing that urge and they can indicate it. And we know that we're going to get more success. Probably by that point, you want to be having a regular bowel motion. So there's a little bit of a pattern in that as well. Okay. I think this is the last slide, and this is just kind of a little bit of a, I'm going to say some random thoughts. So we've just talked about positioning to do poos. Really, really important. Really important that we address any pain, fear, constipation cycle. So any child that has had some constipation, they've had a wide bowel motion, a hard bowel motion, it's been painful. Kids are really good at going, do you know what? I'm not going to let that happen to me again. I'm going to withhold that poo. It's not coming out because I don't want it to happen again. And you basically get this cycle. So any child that's in that cycle, we absolutely want to work out how we can help them to break that cycle, and how we can resolve that constipation for them. Bathroom setup and equipment. So bathroom setup, I'm going to say things like, and this is coming onto the sensory needs point below, have bath mats down on the floor if your child doesn't like walking on cold surfaces. Take into account their sensory needs. So if they don't like the fan, make sure that everybody knows not to turn the fan on. If they don't like bright lights, how can we set up a scenario where we've got a different light that's not quite as bright? Having a little box in there of sensory toys if that's what they need. It might be for some kids that are sensory seekers, as part of that toileting routine, it might be they need to go and crash on the bed 5 times to actually help them regulate before they can then sit on the toilet and stay there for a little while. And they've actually got better regulation. So there's lots of different things to consider. When it comes to bigger pieces of equipment, so kind of, if we're looking at like your Riften commode, your Firefly, your Flamingo, I would always look at getting your local OT involved in that, so we can look at getting them to organise some trials, working out what's going to be the best piece of equipment for your child, what meets their needs, and then what suits your environment as well. I've had families where they've had a piece of equipment that worked really well, and for whatever reason they've had to move house, and all of a sudden this doesn't fit the new house in terms of the setup. So it's really important that we get OTs involved in that so that we're getting the right piece of equipment. Routine and consistency. So that's absolutely key when we're looking at developing that toileting routine. We want to try and create consistency across all environments, so that, you know, if they're with a support worker or they're with grandma and granddad or they're at school or daycare, that we've got consistent language, we've got consistency, so they know what to expect. And for me, in terms of the routine, and I know it can be absolutely chaotic trying to leave the house in the morning. So there's no point in us saying, look, hey, we're going to try and create a routine where we're going to pop them on the toilet 4 or 5 times a day, when, you know, you get to the end of the week and you're like, do you know what, that's just not achievable. Like, we can't possibly do that. So for me, we're better off picking 1 or 2 times during the day that we can actually be consistent with, and we can develop a routine around that. So for me, it's not overwhelming you, it's not overwhelming your child, it's building bit by bit so that we're heading in the right direction and everybody feels as though there's success along the way. Reflex loops. So an example of a reflex loop would be you pop your hand on something hot and, you know, instantly you pull it off. You're not thinking about it, it's a reflex, your body's doing that for you. There are reflex loops that help to stimulate a bowel motion. So, for example, eating food stimulates the gastrocolic reflex, and that basically stimulates that gut peristalsis, so that typically within sort of 20 to 30 minutes having had a meal, your body's trying to move things around and get things out. There are other reflex loops that we can add on top of that to really try and create routine and success of doing a bowel motion in the toilet. And then the last thought I want to just leave you with is withholding might not necessarily be a behavioural choice. So, you know, I do work with quite a lot of children that do have, I'm going to say, behaviours that make things more tricky. But what I'm going to suggest is that toileting challenges are rarely just a behaviour. It's more likely that there's a physical component in there that might then look like withholding, or it might create a scenario where the child doesn't want to sit on the toilet, or can't actually do a poo on the toilet. And it might actually be that there is a physical factor that's causing that. So I'm just going to leave that there. Look, I feel as I've given you loads and loads of information. I hope it's been useful, and I hope you can take away little bits. Feel free to reach out if you need more information. Like Paul mentioned earlier, I'm very lucky to be able to work out at the NAPA Centre on a Wednesday afternoon in Sydney. And then the other days of the week, I'm up in Terry Hills. I think Paul's going to provide this presentation for everybody, so you will have contact details if you need it. And then I've also provided for Paul a bowel chart. So if Paul, if you're okay to send that out as part of the follow-up email, and then any families that do have kind of, you know, concerns around what's going on with their child's bowel function, it's a really good starting point to just start tracking things so we can see what's going on. And it's something that I often get families to do as a starting point. So you're kind of ahead of the game, really. Okay.
Love it. Thank you, Kel. That was very, very, very interesting. We have a couple of questions through which we'll tackle up front. If anyone does have any questions, we do have a little bit of time now to run through some questions, so pop them into the chat. Alternatively, if we get to the end of the questions, we can also get you to pop your video back on, and you can ask the question directly to Kelly. But we've got time for a few questions now, so we're going to fire one at you, Kel. First question comes from someone who I think is in New Zealand, saying, can you provide assessment and liaise with therapists if outside of Australia? I think she/he is based in New Zealand.
I don't see why not.
Yeah. Obviously,
yeah.
will be telehealth based, right?
Yeah, it will be telehealth. I know you guys are doing a pop-up over in New Zealand, but that's not one that I will be attending this year, unfortunately. So yeah, we can definitely do telehealth. Yeah.
Yeah, fantastic. Okay. Also, second question: does the laxatives that you mentioned earlier make gut mobility dependent and lazy? Also, does it impact nutrient absorption? You know
In
that
terms
stuff.
of nutrient absorption, I'm not sure. That would probably be a dietitian that I would chat to around that. I think, look, if you've got a gut that's not functioning properly to start with, having a laxative is not going to impact and make it never work. We want to kind of get things moving so that then essentially the rectum can send signals to the brain. So while ever there's a bigger stool in there, because gut motility isn't as effective as we want it to do, it's more difficult to send that message to the brain. So if we can get things moving, get the bowel emptying better, we've got more chance of getting that that signal to the brain.
Great, thank you. A couple of big thank yous coming through. Someone's asking, should we consult you regarding nighttime wetting? Her child is 7 years old.
Absolutely.
That's one of the services you provide. Yep.
Yep, it is. Yep.
And is there a long wait time to get in to see an appointment with you? The magic question.
The magic question. I think at the moment we're booking into June, but people do cancel. You know, we live in a world where things change at the drop of a hat and people do cancel. So we do have a cancellation list, and as soon as anything changes or moves in the diary, then we do bring people forward or contact on the cancellation list. Yeah.
Perfect. All right, guys.
What I will add there is as well, I am, because I get it as a parent, if somebody is desperate and they suddenly get sprung an NDIS review, which, let's face it, it does sometimes happen, I will always do my best to squeeze you in, juggle things around, and if I need to write a report in the evening, then I will write your report in the evening if it's for a last minute review that's been sprung on you. Absolutely.
That sparks an interesting question, Kel, because I know this question came out last time you did a presentation, but what sort of things, what kind of continence supports can you typically get that maybe families don't know that they can get assistance for through the NDIS?
Look, I think it varies, and I think, you know, I hear lots of different stories from lots of different families. You know, for me, it's justifying those things that we feel as though are reasonable and necessary. So if we look at, you know, the NDIS will say that once a child turns 5, that's when they will add in like your continence related things. But for me, if we can justify that what's going on is related to their diagnosis, which is why they're accessing the NDIS, we can sometimes get funding prior to that 5 years old. But essentially what we're looking at is, you know, what would be above and beyond a parent's expense of a typically developing child. So that could be, you know, your nappies, it could be wipes, it could be skincare products. So there are a couple of nice skincare products that are like no rinse foam cleansers or like your barrier creams and things like that. The other thing that I would always include in there typically would be like your waterproof bedding. So your waterproof bed sheets, doona covers, pillows, your Connie, there's a couple of different brands, your Splashabouts, so your Connie swim shorts for, you know, kids that realistically are growing out of those supermarket swim nappies, but they're in the pool doing hydrotherapy and they can't go in pool without, you know, something that's going to effectively contain things. It might be that we look at you know, the pajama bedwetting pants, that we've got that extra layer of protection. So there's lots of different things that we can look at. You know, we talked about that low-cost assistive technology. I did have a family come back to me this week that said that the NDIS rejected, I think it was the family toilet seat because we put in that it was available from Bunnings and it had to be from a disability provider. So I kind of went, sure, that's fine. We can pay more, but I can put in from a disability specific provider. So, you know, I guess there's little bits that I'm learning as we go along. That, you know, it's never been an issue, but all of a sudden it potentially might be. So we just need to be really trying to justify why these things are reasonable and necessarily and related to, you know, the diagnosis and the disability.
Yeah, sure, great. I feel like this is a question that could be about NAPA, but it's been directed to you. Do you deal with complex kids, the ones who have seen every specialist, done every test, and everyone says that they can't help?
I mean, yes. I mean, look, there's no guarantee that I will absolutely be able to help, but I do feel as though, probably I'm going to say 95% or more of what I do is work with kids with disability and complex needs. So it's not that I typically work with typically developing kids and then see a few kids with more complex needs. Like I said, there's absolutely no guarantee, and we know that with our complex kids. But yeah, I feel as I'm reasonably equipped to work with those kids. Yeah.
Yeah, fantastic. All right, guys. Well, I think that's going to wrap it up for us. Unless we've got any last questions, I'll just do a bit of wrap up. Remember that we've got upcoming NAPA Connects happening every month for the remainder of the year. Some of the topics that I mentioned earlier are toileting and bathroom aids, wheelchair prescription, dietitian and nutrition with Dr. Fiona Arrowsmith, and of the travel one, traveling with kids with complex disabilities, is also a very, very interesting one. Julie Jones has a wealth of experience, writes an annual magazine about it, and goes and tests every airline and asks all the questions. She's the one rattling on the doors, asking the questions. Where am I supposed to change my 17-year-old son? All that sort of stuff. So she's been there, done that, asked all the questions for you, and she will give you the tips in that session, which is the one coming up in May. So a big thank you once again to our very, very special guest speaker, Kelly. You can see her contact details on screen there, but in the coming days or so, I will send you all out an email to the email address that you registered for this event on, with all these contact details, so you can just click on them, that you can make an appointment. It will include that resource that Kelly talked about earlier, as well as a copy of the presentation here tonight. And we will also send you a copy of this video. So if you are bored one night and you want to watch it back again, you can absolutely watch that back again, or pass it on to your friends if you have friends who are in the same situation as you and perhaps didn't get a chance to log in tonight. So a big thank you to everyone for tuning in on this Tuesday night to our NAPA Connects event. Big thank you to Kelly, and we will see you next month for travel tips. Thanks, guys.
Thank you so much.
Bye-bye.